Allow me to share first in. Okay na, Ella? Can you hear
Yes,
me?
ma'am. Yes, ma'am. Okay na po.
Okay,
Yes,
thank you very much, Ella. So I would now start the lecture on pediatric digestive and liver diseases. These are two parts. I separated the diarrheal diseases because that would be next week. Okay, that's our part two because we all know that diarrheal diseases are one of the major causes of, or the top cause of child morbidity mortality. So we dedicate a session for diarrheal diseases. But overall, we will now start on the general overview of digestive diseases in children. At the end of the session, this will just be a summary of our of the asynchronous lectures. You have I hope that you have gone through the asynchronous lecture series, and this session will just be summarizing what you would have read already. Okay. But we are generally, our objective is to make sure that we arrive at a pediatric diagnosis on GI diseases, basing it on clinical history and physical databases that you're to gather and discriminate the diagnosis and the differential diagnosis. We will integrate the principles of management by correlating pathophysiology, diagnostic workup, pharmacology, prognosis, and prevention of the disease. As we all know, when these are the common causes of uh, or the symptoms that will be presenting to us by the children. The GI symptoms of vomiting, abdominal pain, distension, constipation, and jaundice. These are the more common causes that I just chose. And overall, if you are presented with a GI symptom, the first step is really to check whether it is a primary GI problem, okay, or it is a systemic problem with an associated GI symptom. So the difference. So the first step that you would like to ask in your history, okay, and physical examination. Step one, try to rule out if it is a general systemic problem like typhoid fever with GI symptoms, lupus with GI. And then if you have ruled out systemic problem, did you have assess that it is a primary GI problem, then you go to already the next step to check whether it is a medical abdominal problem or a surgical abdominal problem, because often the profile might be overlapping. In this case, always rule out a surgical condition unless proven otherwise. And this will be done by your physical examination again and maybe indicated laboratory parameters. Let us start with a case. Okay, this is a 1 month old unrecalled uh, remarkable birth history and was noted to have episodes of vomiting at the second week of life. So, well, the birth history is essentially normal. Okay, it was feeding until on the second week of life, vomiting episodes started. In this case, you will have to check whether it's an associated GI symptom or it's a primary GI problem. Okay. So, what is vomiting? Vomiting is usually would occur if there is a stimulation of the vomiting center in the medullary area. This would be due to the stimulation from the chemoreceptor trigger zone. If you have a drug-induced vomiting, or you can have increased intracranial pressure when you have brain tumors or space-occupying lesions of the brain, or you will have infections like encephalitis. Can be just psychogenic. It can be the middle ear problems in Meniere's disease. It can be toxins from uremia or diabetic ketoacidosis. All of this would be stimulating the vomiting center. For our purpose, it might be coming from the GI, whether it is inflammation of your intestinal organs there or obstruction. They would send messages up to the medullary center, vomiting center, and the vomiting center would send their messages through the efferent nerves, the visceral nerves, which would supply the pylorus, the spinal nerve, which would supply the abdominal muscle, phrenic nerve, which would stimulate your diaphragm. A simultaneous contraction of this muscle so that there's going to be force. So it's forceful expulsion of gastric content, and that is your vomit. So let's go back to our case, a 1 month old who had a remarkable birth history, but at 2 weeks, this is exclusively breastfed, and at 2 weeks, there was 2 weeks of life, she started having projectile vomit 10 minutes after feeding. What pertinent questions would you like to ask? A, was there fever? Was there passage of meconium stools at birth? Was there diarrhea? Speaking of acute gastroenteritis, maybe this is going to be your first question. If you were thinking there might be a congenital problem in the passage of stools, particularly Hirschsprung, you will be asking for this. These are both primary GI. If you were trying to check if there was a systemic problem with associated GI, then the first question you would be your fever. That is part of your first here. Okay. To rule out first if there is an associated neonatal sepsis. Symptoms also of sepsis neonatorum, you have continuous vomiting. Is ruled out based on your history and PE. You do and try to check if this is a primary GI, medical or surgical. Now, what in the history would tell you that this might be surgical? It might be a projectile vomiting. Okay, so the same question at the 2 weeks old, and you know that there was already projectile vomiting. What would you suspect? Is this allergy, cow milk? Is this milk intolerance? Is this like an acquired functional problem or gastroesophageal reflux? Or there might be a congenital anatomic disorder. Since it's a 1 month old, try to check first, it might be an anatomic. The other questions are still pertinent, particularly if you have a positive family food allergy, then you have to check for. But here are the most relevant question that you would like to ask first is in the primary GI anatomy. Okay, with that being as your suspicion, a congenital problem, what would be your anticipated physical indications on the GI? Upon palpation, would you look for tympanism, generalized gar, a positive fluid wave, you might be suspecting of ascites? Is there a inflammation? Then maybe you might be looking for a congenital problem that would present with a right upper quadrant mass. Based on our readings, the most common might be a choledochal cyst, reflux into susception, pyloric. If this were a choledochal cyst, you would be looking for jaundice. Okay. If this were into susception, you looking for bloody stools. Maybe it is pyloric. As a differential diagnosis, which I from Navarro. You also have that from Nelson. That you will notice that for this particular symptom of vomiting, you have here based on age group, there will be the younger age group you rule out for your congenital problems, okay, and the acquired problems when you become older, and it might be infectious in nature or it might be acquired surgical problems. So the one in surgical problems, the non-GI, the non-GI systemic problems which would present with GI problems would be septicemia, as I've said, problems. And here, as you grow older, here, the adolescent becoming psychogenic for females, always ask for your last menstrual period. You might be missing a teenage pregnancy. Particularly among adolescents, there is a high incidence now of caustic ingestion, those mental stress, suicidal tendencies. Okay, so just a review of embryology. The gastrointestinal tract is really a hollow tube, even up to the fourth week of gestation. To the eighth week, there is going to be development of your epithelial, that's your epithelial growth, which would really occlude the okay? Now, on the 12th week, you have your recanalization. It will open now, but this time with already mature epithelial lining, but there must be a lumen. Somehow, it be an arrest or failure of recanalization, you produce an atresia here, meaning there is no passage and your is occluded, or you will just have a narrowing called stenosis. It's an atresia, there is stenosis, an open passage between two hollow organs, which you call your fistula, and all of this would be presented episodes early on in the afterbirth. Going back to our patient who had a right upper quadrant olive-shaped mass, on the physical examination, you might see if you try to feed this baby, there's going to be a gastric wave of peristalsis before there's going to be vomiting. Okay, and there will be associated hypochloremic alkalosis because the gastric juices are all also um, extruded out. So what is happening is in this area of the pylorus, you will have thickening of the muscular area there. That if you did a plain here is our abdominal X-ray. The air is your black shade, and the soft tissue masses are your white. Okay, so here you will see a gastric air bubble, the stomach bubble, and there is another little bubble there in the going to the duodenum. So you have a double bubble sign. Now, if the patient was subject to upper GI barium swallow, there's usually a procedure where the babies are asked are fed barium. This is a dye that goes through the stomach, it fills up the stomach, but they notice that there's going to be another narrowing area. We call that the stress sign. So all definitely uh, good to diagnose pyloric stenosis. Now, this is a presentation of bile, and it sits from your biliary, from the bile stored in the bladder, and it hits through the sac of Wirsum, the second portion of the duodenum. Okay, this is pancreatic bacteria. If there's obstruction in the it means the vomitus can be built. Okay. Obstruction, just like pyloric stenosis is above the ampulla, then there is going to be non-bilious vomiting. Okay. Let us now go to case number 2. A 2-month-old breastfed baby had an unremarkable birth history, noted to have episodes of postprandial non-bilious vomiting after the baby continued good suck and weight gain. So the baby was still thriving well despite several episodes of vomiting after feeding. There is no family history for allergy, so you ruled out a cow milk allergy, but this is the baby. The physical findings revealed a non-distended abdomen with no masses and no active bowel sounds. Most likely, the question would be it may be you can ask for overfeeding, but if you have a breastfed baby, they usually have good self-regulation. Peptic acid disease is these are usually for older associated uh, uh, no, extended protracted crying. So it might be gastroesophageal reflux. Happens in gastroesophageal reflux. Normally, you have a mature gastrointestinal tract musculature of the lower esophageal sphincter. No actual there. The lower is a specialized muscle that controls closes. So if you have already a full stop here, normally this would close. That's why you have prevention of reflux. In infants, there is still a physiologic immaturity of this lower sphincter. That is why lower esophageal sphincter tone is so lax. It is open most of the time. That is why some of the children would be having episodes of reflux after each feeding. So this one is an example of a GER. Okay. So after about 10 to 15 or even 30 minutes after feeding, all of the contents are spitted out. Well, we call this actually a happy spitter. Usually, it starts at the age of 2 weeks, 2 months old. Okay, it peaks at 3 to 7 months old, and as as the baby assumes its upright position, and the gastric is getting more mature, then there will be spontaneous resolution in 12 to 15 old. Okay. Okay. They decrease by 7 to 8 because of the upright position. Now, if we try to differentiate pyloric stenosis from gastroesophageal reflux, because most of them might have more or less the same clinical profile of vomiting, particularly after feeding. Okay, so you have an essentially well baby for GE reflux. In pyloric stenosis, you might have a baby who is not thriving. The effort is forceful and projectile. Here, it is non-projectile and spitting out. So ito yung mga kailangan i-burp. Ito yung mga matinding lumungad. Okay? And the pathology, you have a narrowed pylorus there. That's why you have a non-bilous. And our GR, you will have a low LES tone. If you differentiated both based on your plain abdominal X-ray, here you have your double bubble. For our GR, you have a normal plain abdominal X-ray. You have normal distribution of gas patterns. This is your very small stomach bubble compared to that. Okay. Because at the end, the air went through all of this up to the lower segments. So if you did a barium swallow, you have here your string sign. For the severe reflux patients, you'll see a reflux from the stomach going back to the lower esophageal segment. For management, pyloric stenosis is surgical, doing pyloromyotomy. For GR, you just have to thicken the formula, or others may be giving proton pump inhibitors. Let us now go to this case number 3. A 4-month-old baby with normal birth history had unconsolable crying for 3 hours duration. This is followed by projectile venous vomiting with passage of blood-streaked stools. Consult was done and the patient was given antiemetics. You have an anti-vomiting, antibiotic, and anti-amoebic. But there was progression of vomiting and bloody mucoid stool episodes. The mother also noted abdominal distension. At the ER, you noted hypoactive bowel sounds and you palpated an elongated abdominal mass in the right hemi-abdomen. Rectal examination revealed blood per rectum upon release of your examining finger. So if this were you were suspecting of something surgical, okay, what would be the consequences if the condition was left unrecognized and you just continued antiemetic, amoxicillin, and anti-amoebic? All of these may occur, correct? Septicemia, but the immediate problem or emergency is bowel necrosis. But you can also have septicemia upon necrosis. You can also have dehydration. Sepsis may be a secondary problem. So these are the complications of probable intussusception. So that was a clinical profile of intussusception, also often mistaken for amoebiasis. So if there is rupture of your intestines here, there is going to be free air in the abdominal cavity. We call that your pneumoperitoneum. So this is an emergency. You have ruptured. You can also, and then upon opening up, you might be seeing gangrenous bowel segments of the intussusceptum. Okay, and this one needs to be resected already. This has an increased risk for gram-negative septicemia. Now, what about colic? Colic has a history of unconsolable crying. Okay, and this is usually among infants less than 5 months old. There is recurrent fasting and irritability. Sometimes the mothers, the baby has a schedule of crying. Oftentimes in the going towards the evening. Okay? But upon PE, you might be seeing a child who is healthy, no failure to thrive, no fever or illness. So this is also one of the differential diagnoses of intussusception, which is your colic, because they belong to the same age group of infancy. Both would have sudden, incessant crying. But for colicky patients, they have a certain schedule every day, every night. There's a crying peak from 6 to 12 midnight. That's why they are often seen at the emergency room during this time. The duration is more than 3 hours. For intussusception, you will have incessant crying, but there is no variable time and duration. Sometimes the mothers in the colicky infants will say, Doktora, dadating na naman yung alas 6. Hindi na naman sila matutulog. Okay? So there is a pattern. There is non-villous vomiting. Often there's no vomiting in colicky patients unless they have associated GER, but they have villous or non-villous projectile vomiting for our intussusception. There's going to be progression of the abdominal distension and passage of your bloody mucoid currant jelly stools. Currant jelly, kung hindi, para siyang strawberry jam. Okay? And if you did your plain abdominal x-ray, there's going to be displacement of the segments here. So most of the gassy segments are in the one side of the abdomen, and you don't know what is happening in this side of the abdomen. Okay. So there is no distribution. Those unequal, we call this the paucity of gases. And if you did your physical examination for colicky infants, it's mostly tympanitic, very gassy. Here you might be seeing you might be palpating a sausage-shaped elongated mass. It depends on whether it is in the right upper or the right lower, depending on what segment went into another segment. It depends whether it is ilioileal intussusception, an ileum going to another ileum segment, or ileocolic, which is the most common, the ileum going to the colon, or a colocolic intussusception. So when you have your intussusceptum going inside your intussusceptions. On rectal exam, again, you have a passage of bloody stools. Here, you will have a passage of a lot of gas. It might be so because it depends on whether the patient is also having gas due to lactose intolerance or high allergy. So here, your treatment depends on what you were suspecting, whether it was cow's milk allergy or GER. So you have to shift to a hypoallergenic milk. On the other side here, you have to refer to surgery because when they do a barium enema here, there's going to be a cut-off point. The barium cannot push through here, and you have a coiled spring appearance for intussusception. Refers to surgery for the procedure. So this is just the paucity of gas, and you have here your coiled spring appearance. So you have here your current jelly stools, paucity of gas, and coiled spring appearance. Let's now go to abdominal pain in the older child. Assessment is difficult because you are actually gathering data from a third party. It might be the mother, because the child sometimes it will be very subjective, but any reported pain must be assumed as real until proven otherwise. Always rule out a mechanical obstruction in children. Again, try to check if there is in your HPI a systemic problem followed by the GI symptom, or a GI symptom becoming systemic. So you have here primary GI, because here you might have other problems like urinary tract infection, bronchopneumonia, typhoid fever, dengue fever, etc. So you try to check which came first. We call that the chronology of symptoms. Let us now go to this 13-year-old girl who had epigastric pain of 1 day duration, 2/10. There was no pain food relief pattern. That is a pattern for your peptic acid disease. But the dietary history reveals that she misses breakfast and takes only midday snacks of soda and chips, which is a risk for your peptic acid disease. There was one episode of non-projectile vomiting. No problems with your urinary, and she had her last menarche, or with a regular menstrual period, 3 months ago. So on physical examination at the ER, there was a tender epigastric pain even on light palpation. Most likely, the working impression would be the risk for the missed breakfast and the chips and soda. But we always put a surgical abdomen in place as a differential diagnosis. So the patient had this pattern coming from the GI. Okay? So it was a GI becoming systemic. So the patient was given something for peptic, omeprazole, the proton pump inhibitor. But 12 hours later, she was brought back to the emergency room because the pain became 8/10. And then there was vomiting and she was doubling up, and it went to the right lower quadrant area. Temperature was 38 degrees and she was looking very weak. So You might be changing already your impressions after the review of the profile. So if you were there in the emergency room, what would you be looking for? Would you be looking for a gold flam test for kidney, tourniquet test for dengue? Would you do rectal exam? Would you do rectal exam and other peritoneal signs? You'll be doing for the extensive abdominal PE. In acute appendicitis, you have three stages: the stage of infection, inflammation, and complications. The first 24 hours might be just a slight abdominal pain, often in the epigastric area. Okay, there is no fever, and if you did a CBC, it was normal. About towards the 48-hour, then there's going to be a peritoneal sign. The patient's right lower quadrant pain is already there. There is a shifting of pain from epigastric area to another quadrant. Sometimes it can also be in the right upper quadrant. And if you the temperature is already about 38 to 39 and the WBCs are going higher, here you have to admit the patients already. And here you have these noted, your segmenters are going higher. If the patient was not admitted, then you have the stage of complications towards the 48-hour. The patient would now have ruptured appendicitis. The temperature is 40, going into septic course. The WBCs are going higher, but you have younger segmenters, the younger WBCs, because the segmenters have been used up already. You have a highly septic individual. So these are the examples of your peritoneal signs. Here you have your Robsing sign when you palpate the left lower quadrant, and upon release, there is a pain in the right lower quadrant. Okay. Then you have your obturator sign when you adduct your right lower extremity here, and there's going to be right lower quadrant pain. The same thing with your psoas sign here when you extend to the posterior area, and you will have right lower quadrant pain. Now, in the clinics, if they basing it on the database that you're gathering, there is a clinical scoring like to help us discriminate whether this is going to be surgical or not. While we are also but we will also be referring to surgery. So we have here a total score, or the Alvarado score of 10, or the Mantrell scoring of 10. All scored 1, but we have 2 for right lower quadrant and 2 for leukocytosis. From migration from quadrant to the right lower, anorexia, vomiting, etc. And if you have less than 4, most likely you can send the patient home, but try to tell the mother we are still we might be in the early stages yet, so there is just observation. Here, 4 to 6, you're not yet sure, admit and monitor. Here, more than 7, admit, refer to surgery, and they check for re-evaluation. Okay, this patient had a severe abdominal pain, 10/10 on all quadrants for 3 days. 1 week ago, he had flu-like symptoms of fever and upper respiratory tract infection. Okay. And upon seeing in the emergency room, you noted that there were skin problems. Okay, so you might be seeing this might be a pattern of a systemic problem with GI manifestations, very severe. So this is this secondary skin allergy with peptic acid disease, mesenteric adenitis, which is a good differential of acute appendicitis. But usually in mesenteric adenitis, you have a 1 week flu-like symptoms before the GI symptoms comes in. But if you have purpuric rashes like this is the condition called henoch-Schönlein purpura. So it might be henoch-Schönlein purpura, and we will just manage the patient accordingly. However, a good differential might be your dengue fever. You still also have a 1 week flu-like symptoms. Then later on, there will be associated abdominal pain. But if you did your tourniquet test like this, it might be positive. And checking on the Herman's rashes of dengue, which is like your lace-like pattern. So your patient has dengue with severe abdominal pain. This is very important. Sometimes they are mistaken for acute appendicitis. That's why there was one case of a patient who has undergone appendectomy, but since there was a decreased platelet, the patient had to stay in the recovery room because of continuous bleeding. They had to stay there for about 3 to 5 days. Okay. So try to check if so this is our patient, systemic becoming GI. Okay. Next question. 1 month old. Are there any questions first before we proceed? Hindi ko makita yung gallery. Are there any questions? Okay. A 1 month old was delivered at a lying clinic. At home, there was stooling that was noted to be on the 6th day of life, okay, because they went home right away after delivery. So a consult was done, and the mother was advised to just insert rectal suppository, which she did, and she has been doing this daily for 1 month. There was some relief, but there would be recurrence until the patient was noted to be irritable with progressive abdominal distension. The newborn screen was normal. So most likely, you might be checking again if there was an anatomical problem. Here, you might be asking if there was passage of meconium stools because you have problems of defecation. The most effective or the most diagnostic test or gold standard if you are suspecting a congenital problem would be x-ray. Others would be doing an x-ray, a rectal exam, biopsy, and an enema. All of this might be done, but the most try to check. So those are your those are your relevant data. So probably it is a congenital problem. Rectal biopsy might be done because you are suspecting Hirschsprung's disease. So we are now in the colon area. So how do we differentiate Hirschsprung's disease from functional constipation? For Hirschsprung's disease, they usually have problems already less than 1 year old. Even if the patient has been discharged from the nursery, there might be ongoing defecation problems. But the most significant data might be the non-passage of meconium stools in the nursery. That's why you have to check for the passage of meconium stools in the nursery. For constipation, functional, this would be occurring based on the changes of the dietary intake of the child. That's why more than 2 years old, when the baby is already able to withhold the stooling pattern, there might be functional constipation. There is failure to thrive, meaning non-weight gain for Hirschsprung's disease, but the functional constipated patients may still be gaining weight. Enterocolitis is a high in Hirschsprung's disease. Both may have abdominal pain because the distension may be there. So poor weight gain for Hirschsprung. If you did a rectal examination, in constipation, you will feel for the fecal material in the rectal vault. So you have a full rectal vault. Here in Hirschsprung's disease, If you did a rectal exam, it is empty, okay? Because the ganglionic segment is actually not distended. The pathologic segment is the non-distended colon. Okay? But you will see on barium enema here, the funnel-shaped barium in your radiologic exam. And you will say, the radiologist would say, there is something wrong here. There is delayed evacuation of barium. We call this your transitional zone. So when the patient is subjected to a rectal biopsy, there will be absence of your nerves, your Meissner's and your Auerbach's plexus. They are not found here. You have an aganglionic segment. That's why this is has to be referred to surgery for surgical pull through. On the other side here, functional constipation. Rectal biopsy is not indicated. Maybe you could just go for dietary modification, behavioral modification, and the use of laxatives to loosen up the stools. Both will have good prognosis. So, what is happening in functional constipation? When the older child starts to withhold their stooling, the rectum becomes distended, overly distended, so that it can accommodate the bigger stools until a certain point when it becomes overstretched rectum already. So in functional constipation, you have a mega rectum producing this type of your Bristol stool 1 and 2 and 3, okay, as in contrast to megacolon in Hirschsprung. Here it's a mega rectum. It's acquired. Okay. Let's now go to this newborn baby who was delivered with no perinatal complications. The prenatal history was unremarkable with a mother's blood type of O. On the 12th hour of life, there was generalized jaundice. Is this physiologic or pathologic? So some of the residents asked for the baby's blood type because the mother's blood type was O. They thought this would be pathologic because the physiologic jaundice would occur beyond 24 hours towards 48 hours of life. Okay, it's physiologic because of the immaturity of your liver, and the liver enzymes are not yet well developed. So if the baby was the residents were asking for a blood type, then they might be thinking there was an ABO incompatibility. The total bilirubin was elevated. For in this case, what bilirubin fraction would be expected to be elevated? Is it B1 indirect, B2 direct, or both? In this case, it may be indirect hyperbilirubinemia. What are the causes of indirect hyperbilirubinemia? Most of the time, because we have a red cell problem, you will have hemolysis, okay? So the most common is your ABORH, but you can also have spherocytosis, G6PD deficiency, or your hemoglobinopathies. In the nursery, if you have a non-hematologic problem like birth trauma, when there is a collection of blood in the cranial, in your skull, you have your cephal hematoma, then you will be expecting early onset jaundice. The reason why we have to monitor bilirubin levels in the newborn is because we don't want your indirect your bilirubin 1 to cross your blood-brain barrier and cause a CNS problem. That's why in the nursery, they are actually monitored and they are plotted against this normogram to see if the baby belongs to the high-risk group or the low risk group. So this is your hours of life in our patient, the 12th hour of life. And if she had a bilirubin level of 10, the patient is already in the high risk group. Okay. But if you have a 72-hour or a 60-hour patient, 60-hour-old patient and you had a bilirubin of 10, is just here in the low. Okay, so there is no problem here. But if your patient belongs to this problem, this area, okay, then you have to have other plans, and maybe neonatology would be explaining the reason why they do an exchange transfusion or just give phototherapy. So the dangerous level would depend on the age of the patient and the level of bilirubin when you get worried, okay? Because the bilirubin 1 is lipid soluble. It can cross the blood-brain barrier. It gets deposited in the brain, and there would be what you call kernicterus. There would be, particularly if the bilirubin was deposited in the basal ganglia, you might have problems with movement disorders or seizures. Now, for patients who are jaundiced and you are the plan is to do phototherapy. They are subjected under the blue light, about 460 to 490, for effective isomerization of B1 to become B2, which is more liquid or water soluble, so that it can be disposed of in the urine. So the patient is under the blue light phototherapy. Okay. Okay, next case is a 3-week-old baby who is exclusively breastfed with normal birth history. Was noted to have abdominal distension and generalized jaundice at 3 weeks. Is this pathologic or physiologic? It might be pathological. You might be thinking it might just be a breast milk jaundice, but it might not be a physiologic jaundice anymore. So, what questions would you like to ask? Maybe if you're trying to look for a systemic problem like sepsis, oh yeah, that's a correct question. ABO, that's too late already. Hepatitis B, maybe no. So try to ask for the color of, you have to ask for the color of the stools. So this is just your bilirubin pathway or the pathophysiology of jaundice. So here we already talked about the RBC problems where you have increased hemolysis. When you have hemolysis, your hemoglobin would give you your biliverdin converted to bilirubin 1. Bilirubin 1 travels to the liver through the albumin transport mechanism, gets conjugated in the liver, and then becomes bilirubin 2. If there is obstruction there, then you will have a direct hyperbilirubin elevation. If there is intestinal obstruction, you can also have increased enterohepatic circulation, and the B2 is converted back to B1. So anywhere along this pathway would produce jaundice. Okay, you just have to know whether it is indirect or direct. Now, for these 1 to 2 month old babies with the same clinical profile, try to check whether your stools are white or not, because the here, once the bile, the bilirubin 2 is in the lumen here in your colon, they produce your pigmentation of the stools, and you must have yellow stools like this. Okay, so that try to ask if the color of the stools are white, because you might have neonatal cholestasis for direct B2 hyperbilirubinemia, whether you have inflamed neonatal hepatitis or obstructed biliary atresia. These are your stool colors. Okay. For breast milk jaundice with indirect hyperbil, you still have normal stool color. So this is okay. Here you have to refer, try to check if this is a surgical problem. That's why they are also referred to surgery for further diagnostic procedures. So for our level, if you see white stools, you have to refer that. A newborn baby was delivered with no perinatal complications. Prenatal history was unremarkable. What routine birth vaccines should be given? HBIG, immune globulin, A, B, all of the above. Okay. You give your routine birth vaccine, your hepatitis B uh, antigen. You don't give your immune globulin. You just, unless there's a history of a maternal hepatitis B ongoing during the pregnancy stage. Hepatitis A is not given during this time. Let us review the antigens and the antibodies for hepatitis B. So this is your hepatitis B virus. In the surface, you have your hepatitis B surface antigen. Its concomitant antibody that would be developing would be your anti-HBs. Okay. In the core, you have your HB core antigen, which is not found in the blood, it's just within the core. But its concomitant antibody would be your anti-HBC IgM, which denotes acute active infection, and your anti-HB core, which is with IgG, which denote um, past infection. Your hepatitis B E antigen is also within the core, but it can be reflected in the blood, and the concomitant anti-HBe antibody would develop later. If you ask for the DNA, you can ask for the HBV DNA. It can also be detected. If you have a patient who has a flu-like symptoms 2 weeks prior, although there is already an incubation of 8 to 13 weeks for hepatitis B, later on producing jaundice, and you ask for your hepatitis liver enzymes would be elevated, the markers that you will be asking during this phase of acute infection would be your HBe antigen, your surface antigen, and the IgM. If you did that, your patient is in the acute phase of hepatitis B. Then later on, when there is already resolution, okay, then your patient will be developing the anti-surface, which means there is protection and immunity. But sometimes, if you see a patient in this area where there is no anti-HBs yet, then sometimes there is no HBs also. Then a negative HBsAg does not rule out hepatitis B. You are in the window phase. Okay. So in hepatitis B serology, when you have a surface, an E, and an IgM, you are in the acute phase. Positive E antigen means you have active viral replication. Okay. So if it is IgM, it is acute. If it is IgG here, it might be a chronic infection. So these are the combination um, of your profiles. So if you have an anti-HBe, it means that there is no active viral replication, there is low infectivity. But the most important marker we'd like to see is your anti-B surface. So for this, if you have an HBs positive, it means and you have an E, there's active viral replication, and you have an IgM acute. So this is acute hepatitis with high infectivity. So that is in this part here. Now, if you have here a negative S surface, no more infectivity, you have a lot of antibodies already, and you have an IgG, then that means that you are already in the recovery period. If you do not have these other markers, but you have an anti-HBs alone antibody, and you didn't have a core or an E, it means that this might be the marker for those who have been vaccinated. Now, the most important thing to check is in the clinical course, because if you go beyond 6 months and you still have a positive HBsAg, your patient is going into the chronic hepatitis B, and we don't want already the risk for hepatitis B, like your hepatocarcinoma and your cirrhosis, okay, which would develop in so many years after. So that's a danger point. This patient has to be monitored. I think that's the last of my. Are there any questions? Ayun ko lang narinig. Do you have any questions? So I hope that you have actually gone through the lecture that we prepared before the synchronous lecture. Go through the asynchronous lecture. And if you have any questions on that, maybe you can ask that for next week. Next week, we'll be dealing with diarrheal diseases. Okay? Okay, if there are no more questions, thank you. Thank
Thank
you
you,
very much.
ma'am.
Bye.
Thank you po, Doc.
Thank you po, Doc.
Okay. Maybe prepare your questions for next week.
Recording stop.